If you're ready, Nikki, I'll start if that's okay with you.
Well, thanks for having me.
That's great. Well, thank you very much indeed. So we'll start off. So we've heard a lot during the latest pandemic about the pressure on secondary care, but very little in the media about primary care, even though in most areas, and to some extent also in Nottinghamshire, primary care is doing an awful lot of the work here. And I think we feel a little bit abandoned. Does the department realise what this is doing to staff morale, and are there moves afoot to improve this, please?
Okay, well, first of all, and you're going to expect me to say this, but can I just say a huge thanks to everybody in Nottingham? You've done an incredible job. I was just having a look at our Foundry and Inequalities tool, and the work that you've been doing locally, particularly in the vaccination space, but before that as well, is really, really inspiring, actually. So I'm very grateful for that. And we have a difficult meeting with the media, in a relationship with the media, because obviously we've got a number of things to do. If we think about this from a vaccination program, and then we'll talk about wider general practice, we want to build confidence in the vaccination program, but the way that has really happened has been through general practice. The role of the wider general practice team in the program has been really quite incredible. And actually the role of the wider team to be there throughout the pandemic. The media is tricky, as I said. It more often than not looks for negatives. I mean, you can only look at Meghan Markle to know that. But we know that primary care has been working well above and beyond what we've what anyone could have dreamt of. The pandemic has shown a really strong light on the health inequalities in our community, and many of us have recognised that for a long time. And the role of primary care and the strength of primary care in tackling that becomes more and more critical. So I think one of the things that we need to be doing is always talking about the pressures that general practice face, but I'm also really, really clear that we should be talking about everything that general practice is doing. And so everything that we talk about now is really clearly amplifying what general practice in the wider primary care team, what you're achieving, what we're achieving, and what we've been delivering through the COVID programme, because that's what we really need to do, is champion actually what we are doing. There definitely needs to be more to help the public understand the changing role of general practice, partly around remote triage and access, but we have got a kind of comms pack and approach, and we're constantly updating that. So if there's more that we can do in that space so that the public knows what to expect from primary care, we're really, really keen to do that.
Okay, thank you very much for that. Hopefully that means you're definitely on our side, because we do feel
always.
So the second question is about health inequalities, and we heard this morning from Carter about some of the issues here. So the question goes: the pandemic has further highlighted health inequalities, and the current Cahill formula perpetuates the inverse care law. Primary care has a great data set, and the use of this data has the potential for true population health management. Can NHS England commission a Q health inequalities algorithm to replace the outdated Cahill formula?
I think that's a fabulous idea. So I think there's probably three phases to this. I think there's what do we do right now about health inequalities that are really, really pressing and really palpable through COVID and through the vaccination programme. And for example, some of the stuff Carter's been doing is exactly on the nose. That's exactly what we need to be seeing in local communities. And we can see the improvement against IMD and ethnicity in terms of uptake in your patch because of initiatives like that. So the immediate term, we released funding yesterday at a system level so that we can do more kind of community events, more community focused engagement. And we've got more fluidity around the contract so that we can have more pop-ups, more ways of building confidence into getting your vaccine. So that's the immediate bit. I think then there's a middle term bit, which is the commitments we made around health inequalities in those long ago days of the PCN DES. Look, I'm really clear that when we hit April, we cannot start turning on a bunch of stuff because we are tired and we've got a lot happening. We've got a lot happening from COVID, from routine care, from the vaccination programme. So I'm not at all saying we suddenly need to turn on the PCN DES in the way that we would have done if we didn't have COVID, but we do have a strong health inequalities element to that, and that for me is a shorter term kind of refocusing of what we do through a health inequalities and a health equity light. And then the longer term is absolutely about the funding as well. And so we're going to have to, and whether that's a Q health inequality algorithm or whatever that is, we are going to have to look again and say, what does this mean? But we need to do that with local systems. We need to do that in a way that's fair. We haven't looked at Car Hill for a long time because it always creates more losers, even where it creates winners. But I'm massively committed to addressing inequalities through how we allocate workforce, through how we allocate future initiatives. So I think it's multi-phased, and we are absolutely here to do that.
Thank you, Nikki. I take your points about the Car Hill causing more inequalities. And I remember when the new contract, which is no longer new, of course, came out, and we had what was called Black Friday with all sorts of underfunding problems. So we certainly want to avoid that. But there are health inequalities that yet remain to be addressed, of course. So thank you for some reassurance there. The third question is a little bit on the long side. I'll try to précis it. So I appreciate that the pandemic has been a rapidly evolving programme, and many strategic decisions about financing and delivering the vaccination rollout have been made at pace. However, many GPs feel that deadlines and targets followed by strategic U-turns are unfair and undeliverable in a safe way, at the same time as delivering core contractual obligations. General practice is built on goodwill and trust. Communication and transparency are crucial, but the content of communication is arguably more important. I feel that you have been a great proponent of general practice since you've been in post. You're a great communicator and you take people on your journey, which is great for inclusion and fostering belonging. However, how do you suggest we can improve conditions for general practice and reduce the impact of the disconnect between shop floor GPs and the powers that be, both during the pandemic and in our new normal moving forwards?
What a great question, gosh. So if I just take a moment to reflect on the pandemic, it was and has been and continues to be for all of us at all levels incredibly chaotic. Things change. I mean, certainly this time last year, things were changing every hour. And even in the vaccine programme, we will have just been in an allocations meeting, so we will hear of a supply change, for tomorrow, and then we'll have to work to decide what we do with that. What I wanted to say when you're reading out that question, I thought the thing that I really want to say is that there aren't people who are against general practice in this, and often get kind of questions saying, why does everyone hate us so much? People don't. I'm here living and breathing saying I'm absolutely clear that people in the organisation, through the organisation, are really bothered about general practice. But you're right, we need to make sure that voices are heard in a really clear way. And I think we've been robbed, haven't we, of kind of time, even though in the pandemic we've had lockdown and we don't have all the kind of family and social engagements in the same way. We have been stripped of time, and a really rapidly evolving policy landscape means that we've not been able to engage in the way that we would like. So I've really welcomed the fact that people have been flexible. So they've joined webinars, they've been on WhatsApp groups, and people have fed stuff in. And I think that is important. And hopefully people see that really does change the way that we do things. I think what I'd like to see more of now is that clear general practice, and I mean that as the wider team, not the GP, but the general practice team voice reflected up and out of the PCN and into the ICS as well. So, I mean, the top of your question was, how do we improve conditions for general practice and reduce that kind of disconnect? For me, that has to be, we do the top-down listening, hearing, and learning from the shop floor, but at the same time we have a stronger general practice voice, with your own stakeholders, with your LMC, and through your ICSs, because actually your general practice and the wider PCN has the greatest agency for how care is delivered locally, and we need to keep building on that. So that kind of join up is going to be the real key to improving, not just improving conditions, but improving care for the population.
Thank you. You've segued fantastically well into the next question, actually, because the next one is about ICSs. So with changes occurring to position ICSs at the forefront of decision making as far as commissioning is concerned, how do you feel GPs are going to be, or indeed should be, represented on ICS boards? We've previously had representation on CCGs, before that PCTs, PCGs. How is the GP voice going to be officially heard within the new organisation? And of course, we're really interested. LMCs have been, the voice of GPs for so long, and we are a force for good, we hope, for general practice. But ICSs, it would appear that we don't have an official way in there if we're not careful. And I think that could be a disaster. We need to work together in the health community and see what your views are.
Yeah, so I'll be really clear here. LMCs must and should and always will have a voice. We can't and we shouldn't be developing systems without LMCs. And we need the voice of general practice at scale, whether that's a federation, through the PCN work. It is the multiplicity of providers and the way that we work that makes us really good at what we do. So I absolutely see a role for the LMC, the general practice team, the PCN, the federation at an ICS level. For those that aren't aware, the integration white paper is still being consulted on, but it has in there already a minimum requirement that general practice representation has to be there at an ICS level. And we've been doing some thinking in the background about what clinical leadership looks like within that system. But there is no doubt that needs to happen. I think the other way though as well, so through your general practice and LMC, through your PCN voice, absolutely clear, but also through your health and wellbeing board as well. And what we want to see, what I certainly want to see, is greater integration at a local level, at a place level. Because I think if COVID has shown us anything, it is that we must work even more closely with our local authority and community partners. So Greg, this is definitely an open call. If Nottingham general practice isn't represented in the ICS, I want to be able to help that to happen, because we need to see that. We need to see that in every ICS structure across the country.
Thank you, Nikki. That's very helpful. Is there going to be a statutory obligation on ICSs to come back to LMC, do you feel, or is this going to have to be voluntary?
I'll have to check, Greg, because I think there's probably both. I think there's both a statutory need to understand general practice within an ICS structure, and then I think there's something more that LMCs also provide on top of that. So let me take that away and bring it back to you.
That'd be very helpful. The other thing we don't want is postcode differences throughout the UK, because that would also not go down well. So reassurance would be very helpful. The fifth question is about money. There's always going to be money questions here, aren't there? We spoke earlier today about the old GP Red book, which many of us will look back to with some fond memories. The link between GP expenditure and reimbursement has been long since broken, and that was enshrined in these strictures and before. However, GP expense as a direct result of changing working practices with COVID has increased massively in some cases. Has provision been made for that in expense reimbursement, either directly as direct reimbursement or in the global sum monies yet to come, please?
So I think it'd be good to hear from yourselves on this, and maybe this is an offline conversation, but I think there's two things here. For me, there is, what have we done in the best interest of general practice to make sure that general practice can navigate a very complicated year? And as we said earlier, it has changed rapidly. So one of the things that I committed to before I knew about COVID was we would stop doing sort of piecemeal funding. But we've had to do that this year because something has come up and we thought, oh, we need to put money out. So I do apologise for that, and I'm absolutely at fault for that, but there hasn't been a choice. But if I look nationally, I would say, look, we've done a range of things to try and support general practice through the pandemic, not just in terms of the vaccine rollout. Let's think prior to that, funding, contractual changes that we've tried to put in place to support general practice for the best part of a year. The 150 million additional funding for the CD role, which is also, you can also divest into other team members, recognising the value of the wider team. The additional funding for different care setting, vaccinations, the new to partnership scheme, you know, trying to keep up with the other commitments through the GP contract. The second part of that, though, is how that's then received locally. And I don't know if somebody is here from the CCG, but it has to be a kind of a joined up approach. So then when we describe these different funding opportunities, actually locally someone's saying, right, these are the different things that are available, but this is what's needed here in this patch, and this is how we're going to make sure that we put the funding pots together. So it really means something. So for example, you know, if someone's having, having pop-up clinics, nobody should be at a loss because of that. And we had estates funding separately at the beginning of the programme, and we've now got another approach to pop-ups to support. So if that isn't happening, if that join up isn't happening, then, you know, we need to work on that, because we need to be able to support general practice to work in a really complicated environment. And then I will say that kind of bottom note then around the global sum, further kind of negotiations then happen with GPC, as you know, and we'll need to be reviewing what the next year looks like. Again, this wasn't part of our 5-year kind of general practice and PCM plan, but we need to kind of think about what this means going forward in lots of ways, you know, notwithstanding things like long COVID, the impact on staff, lots and lots of things to think about.
Thank you, Nikki. And perhaps we are a little more protected in Nottinghamshire because of the way the system's been set up, but we have heard from neighbouring counties about massive overtime bills yet waiting to be paid and reimbursement flowing. So it was a valid question. And of course, this is going to roll on, and this rolls very nicely into question 6. So someone's put these questions together very cannily, Michael. I think it's you've done very well there. So this is about the changing deadlines for COVID vaccination programme, but also the potential for an annual booster in the same ways we do for the flu campaign. And once we have coverage on our 2-dose for all our patients. And asking really about emerging thinking from the NHS about ongoing protection for COVID. Perhaps not just from are we going to have a winter booster, but also other measures that the health service in general may need to put into place.
Thank you, Greg. So, I mean, part of this is obviously the being guided by the CMO, and particularly the Deputy CMO, Jonathan Van Tan, who is responsible for conducting some quite large-scale studies about the impact on transmission of COVID. I mean, we all think there's a theoretical impact on transmission, that feels sensible, but actually what does that mean? What does the impact of transmission of COVID post-vaccination mean on the NPIs and lifting them? We've got a roadmap now from the PM, but actually, you know, that's going to, for us in general practice, feel quite complicated. We are well into the heart of vaccinating cohort 6, where they're going to have a run of second doses to deliver, all in the context for these few weeks of a relatively limited supply, which is complicated to deliver. I really do get that. And then we've got the wider population to vaccinate as well. And I guess, and it'd be good again, and it might not be in this forum, but do feed back to me, I'm sure through Michael might not mind, but you know, how do we get the balance right? Because general practice has done a phenomenal job in COVID vaccination, but at some point we've got a lot of work to do as well, from patients who haven't come to us and all the kind of built up demand in the system. So how do we get the balance right? I am absolutely clear that general practice LVSs are the right model for delivering better equity of vaccine, access to vaccine and uptake to vaccine, but we've also got a really big job to do. That is then overlaid with a potential booster programme this winter. So back to Jonathan's trials, the other trial is, do we need a third booster? in the winter, autumn, winter? Can we give that with flu? So that's what we're trying to kind of learn from at this point. It's all very much learning as we go. We also need to understand the impact of new strains. So that will be with JCVI, Department of Health, Public Health England as well, to kind of agree a strategy of how we manage this in the midterm. So the midterm being over the summer, and then into the longer term. So what does this winter look like, and what does that mean for the next winter as well? So for me, that looks like, you know, a really big job for us still, but trying to manage that right so that we are able to see our way through it. Look, our immediate priority has to be cohorts 1 to 6 and focusing on the stuff we can control. So cohorts 1 to 6, and particularly going back through and making sure our ethnically diverse communities and our health inclusion communities get that vaccine when they feel confident to do so.
Thanks, Nikki. We'll obviously learn more when Jonathan's got his research done. Hopefully we'll hear fairly quickly from that. Question 7 basically says, what do you think general practice will look like in 5 years' time?
Oh, I did have views of what general practice looked like. Look, I'll be really honest. I still think we'll be reeling a little bit from this year, because this year won't be finished this year. There'll be another year of it, and then there'll be another program. You know, vaccination, if it's annual, you know, that is another shift to the way that we've worked. But the pandemic has also brought out the absolute best of us in general practice. It has shown what we're capable of doing, both not just remotely, but with an incredible diverse team. You mentioned Hussein's session just now on social media. I think, you know, the real beauty of this is that we will be able to work with our communities in a different way, and I think that has a wider implication for society. So I think we have a really exciting future despite this year. We have a thriving and diverse workforce which is supported and growing through additional roles. So I think we have PCNs going from strength to strength, and even more importantly, and really key to what I think I represent, is that we will play a bigger role in tackling health inequalities in the way that we've already described. But you know, we will be living with this as a society for years to come, and it's general practice that people will turn to, that people will trust, and that's what we're going to need to be ready for.
Okay, thank you very much. And what about, can I ask about your ambitions for primary care networks? These are relatively new, they're still evolving and changing. We're all involved in one shape or form. And do you think they should continue to be small local entities, or do you think they should become bigger?
Oh, they are small. The whole philosophy about PCNs is you maintain your own practice arrangement within it, whether you're a big practice or small practice. And we have some practices that are their PCN, and we have some that are made up of lots of smaller practices, and that's entirely right. It has to reflect the local workforce and the local community, particularly with the integration white paper, where we have that kind of geography at an ICS level. What we also really need to be able to see is the role of the PCN with the constituent kind of general practice membership within that. So I don't expect it to grow in terms of size, in terms of I also don't expect it. There's been some interesting conversations that I've been part of where people say, well, don't you want us to be contracting? And I sort of think, no, gosh, that would be the worst thing to do. Actually, what you want to do is come together and do things at scale where it makes sense to, in the way that you have done through the pandemic and through vaccination, but also keep the value and the beauty of local list-based personal general practice as well. So PCNs will have a role, but it will stay close to the practice, because I think that's the way that it adds value to the system.
Thank you very much. Now, we did actually have 10 written questions, but I'm aware we're getting very close to the end of your available slot. And there's a couple of questions that have popped up in the chat, which I think would really quite like to ask. So one of them talks about the increasing backlogs of elective care, pressure flowing back into primary care. How do you think the system can support and fund this to absorb what at the moment is potential hidden work?
Yeah, really good question. And we're trying to just, well, we've started to understand the scale of this, and I mean that in a really quantitative way. We've all felt it in general practice, but how do we quantify it and make sure that we can understand how we work through this? I think it has to be a really joined up approach, actually. I am our best advocate, as in general practice's best advocate in every meeting I'm in. I always am and I always will be. But I also think that we have to behave as a system in this space. This is unprecedented. And what we can't do is end up with a massive backlog of care, nobody owning it, and then our patients, our local population sort of struggling. What we started to do through the pandemic is try and take a really person-centered shared decision-making approach to this. So testing it in a few modalities in a few areas, and essentially asking, so if you take a surgical specialty, it's easier to explain, but asking a clinical surgical team to work through that backlog, speaking to that individual, where appropriate, then speaking to the GP who will have that better knowledge, relationship, etc., or member of the general practice team, to try and understand where that person is on their kind of diagnostic journey or their elective care journey, whether they need to have that procedure now or down the line. It is going to take us a really long time to work through those. But like I said, it's going to have to be done together. It's going to have to be really strongly clinically led. Primary care is going to have a role within that, because we will otherwise have patients who just aren't getting care, but we're going to have to reflect that in what we what we describe with GPC and others as well, to make sure that we get that in a supportive way for general practice.
Thank you, Nikki. We've got a question which is really forward thinking around infrastructure funding for premises as education of trainees and medical students being held up by room availability. This also crosses over to some premises discussions we had early this morning with Richard. And it concludes by, sadly, infrastructure funding isn't currently released for educated practices. Can this be changed? And of course, if we don't have the future trainees and the future students, we don't have future general practitioners, and we are already a scarce breed.
Yeah, so I agree with that principle in the way that you've described, Greg. I think broadly, infrastructure funding, we will vaguely remember the interim premises review, which was dependent on a funding allocation sort of 18 months ago or a year ago, and then we had COVID, and that's sort of come off the radar. I think we need to revisit infrastructure in a much wider way now. So, you know, what does premises look like going into the next 5 years? How do we move away from the last person standing? So I think there's a whole host of things within the premises conversation that we need to understand and recognise actually that we will have a limited pot, and we will work with GPC to understand how to attribute that, whilst recognising the principles that you set, which I do agree with.
Thank you. We're almost there. I've got one question on the sheet though, which I think we must ask you. Is a slightly personal question. It is, what's the most rewarding and least rewarding aspects of being the senior GP working within NHS England?
What a great question. I think the most rewarding genuinely is things like this. I've really enjoyed meeting people around the country, you know, whether it is the Sun's favourite GP, you know, local GPs. I mean, you know, I'd spent I've had a couple of visits actually your way before the pandemic, and it's kept up through the pandemic. It's been virtual visits, and it has been virtual visits to vaccination teams, which has been fun. But that's definitely the bit that I've enjoyed the most. The way that people have innovated, the way that people have just care for their community has been absolutely incredible. And so learning from that and seeing it and then feeding it into national policy is definitely the most enjoyable bit. I guess the one least rewarding, you know, press briefings might come on to that, you know, might be one of the things that certainly put me in a slightly uncomfortable position. I much prefer these sorts of forums, but yeah.
Okay, thank you very much. Nikki, I think we are now actually out of time, because we have I know you're very busy, but we also have a timetable as well. So I'd like to thank you very much for taking time out of your, what must be an incredibly busy day, to come and talk to us today. We're very, very grateful. If there are further questions, we might just drop a few down the line for you in due course. But thank you very much indeed.
Happy to. Thank you for having me, and thanks for everything you're doing. Bye-bye.
Thank you very much indeed.